Okay, so far we talked about observational studies, and we're going to go back to observational studies later, but now I want to talk about intervention studies and specifically randomized controlled trials. Now, there's a lot of commercial trials going on in the hospital, but you can also think about kind of more internal clinical research that lends itself to this kind of design. You know, trying one treatment or one intervention in one group versus another group. Like this is what Tali's doing. And by the way, it doesn't have to be about a drug. It can be any intervention. It can be running. It can be information. It's better than drugs. Exactly. Yeah. It is an intervention, of course.
The best one. No.
Right. So really the main difference about the observational studies that we did so far and an experimental study or intervention study is that before we just observed what happened. We didn't touch the patients. We didn't do anything specifically. Here, the patients are randomly allocated to receive or not receive an intervention, and then they are being compared in terms of their outcome. So of course, you can also do intervention studies where patients are not randomized, but that's generally not very good practice. So some of the key features of randomized controlled trials, they are prospective because you give the intervention by design they are prospective. You give the intervention and then you see what happens. The main thing compared with what we talked before is that the intervention is under the control of the investigator. You expose your patients. An exposure could be a positive exposure. Obviously, we don't expose people to harmful things on purpose. That's unethical. But it's an active act, and there's at least 2 comparison groups. You can have more. You can have a trial with more than 2 arms, with 3, 4 arms. You know, when you do, especially in in oncology, you have this plus this and this, or even in in vaccine trials, you can have like for example with a number of doses, or we did one study with Men-B vaccine plus paracetamol and no paracetamol to look at side effects. You can have many groups. The allocation should really be random. If it's not random, you really open yourself to a lot of problem. And wherever possible, you should blind you can have single blind, double blind, triple blind. We'll talk about this. It's not always possible, but if you randomize and you blind, you basically almost eliminate confounding and bias to a very large extent. So if you can do it, it's highly recommended. So we saw this graph, we saw this before, but it summarizes the sequence of events. You have a population, you identify a group, and you invite people, you randomize them to intervention and no intervention, and then you look at the outcome. That is the basic sequence of events in a randomized controlled trial. So the goal of a randomized controlled trial, the difference between an observational and an intervention study is that an observational study is also, now observational studies is not a fashionable term. People use real world evidence, because real world evidence means you look at the real world and the real world is messy, it's complicated. And a randomized controlled trial is the epidemiological equivalent of a lab experiment. It's an experiment. You control the conditions. The conditions are not the same as real life. And this is really important. And this is why observational studies are really important. And, when people say, oh, I only believe in RCTs, it's nonsense. Because, for example, in RCT, you may pay people, people are paid sometimes to do RCTs and to receive an intervention. It doesn't mean that in real life they're going to continue doing it, even if the intervention is positive and has a positive impact. So the complementary types of studies, but essentially in an RCT, you create experimental conditions where the only difference is whether or not they receive the intervention. So you can be not certain, but much more sure to a much greater extent that the association is causal. So the first key element to really the key to this is randomization. And you need to allocate your subjects, and your subjects don't have to be individuals. It could be part of an individual, it could be a blood sample, a tissue, it could be a person, it could also be a group of people, it could be one town versus another town. You know, if you're doing fluoriding water in one town versus another town, then you go into kind of cluster trials, which is a different type of or subtype of RCTs, but it's not necessarily individuals. And the allocation has to be truly random, right? And sometimes you have things that look like they're random, but they're not. Like, for example, saying, oh, you know, every other patient going there into the intervention, into the trial, that is not true randomization, for example. In true random allocation, no one should be able to predict who will be allocated to which group.
So it's not one like that, one like that.
No, because if you do that, you know
The next
who is
person
this,
comes
and
in.
maybe you think that, for example, one patient is really likely to benefit, and you're going to fetch them. Not so you shouldn't be able to predict who's going to be in each group, right? Tell you this is going to be very important for you, because if you think that, you know, maybe you think, oh, this person, you know, he really hates exercise, I don't think he's going to comply, so I'm not going to include him. Don't do that. So real randomization is random. So you can imagine in this group you have purple people and red people and green people. This is very politically correct. And then if you don't truly randomize, well, maybe you think, you know, I think maybe the green people are younger and healthier. And you think, you know, if you're doing a trial, generally as a researcher, it's because you believe that the intervention is going to be positive. You don't have the evidence, but so maybe you think, you know, unconsciously you're going to think, oh, I'm going to give the intervention to people who are going to do well. You know, if you want to show that running works, if you ask people who love running already to run, you know, that it's going to work better than if you get people who like don't get off the couch. So that's why true randomization is really, really essential in randomized controlled trials. So the other advantages, the other things, age, sex, you know, their background, because it's randomized. If your sample is big enough, it will equalize, so you won't have confounding. And you test for that. You know, the table 1 generally in your paper is the baseline characteristics of those who receive the intervention. And the reason you do this table is to show to the readers that your randomization worked and that the two groups are basically comparable. As we said, allocation by systematic method. So if you alternate between people, if you use people born in this year, go to the intervention, and this is not true randomization, and it may seem very minor, but it can bias your results. So if you're going through the effort of already randomizing, do it properly. And as we said, you have generally the reason you have these tables is to show that that the groups are randomized, that the intervention and the control characteristics are very similar. And this is not because this is interesting as such, but it's basically a proof of good randomization. Now, blinding or masking is another really key feature of RCTs, and it's not always possible, but with drugs generally it is. And it's basically concealing the allocation to the investigators, to the subjects, and if you can, even to the people analyzing the data, right? So for drugs, it's generally possible, but you can see how expensive it is, because you have to make, if you're making a placebo, you have to make a drug that looks the same, that is in the same packaging, etc., but doesn't have the active ingredient. for, you know, the type of intervention you're talking about, you can't be blinded, and that's okay. But you need to explain why. If you're not blinding, you need to explain why you're not blinding.
Sometimes you cannot blind for the person who gives the intervention, but you can blind the person reading
Correct.
the information. And then it's,
You can blind. You can, in your case, Tali, you can't blind to the investigator,
you can
but you can blind to some extent to the participants. You can't tell them. Of course, they will know whether they're running or not. But if you don't tell them that the intervention, you don't say, we're doing a study to understand whether running is good for you. You just say, we're doing a study to understand factors that will positively influence your mental health. And we're trying different types of interventions. Like, so you don't make it that the running group is the good group, and you see what I mean? That is the form.
The whole time, like, how do I present?
So it's a form of blinding. It's not complete blinding, but it's kind of partial blinding.
Yeah, though it's obvious that if you do physical activity.
for you, for the girl.
Well, if you're doing a movie about well-being,
For me, if you tell
maybe
me
you
to
don't-
run, I mean, then
if the movie is about well-being, maybe, you know, maybe it's not clear. Maybe it's not clear. Yeah. And yeah, I mean, so if you can blind, it reduces the likelihood of bias, because patients, you know, obviously, if they know they're receiving the information, the intervention that will make them feel different. If you know, then you know, you may treat the patients differently. But this is not, randomization is always possible. Blinding is not always possible. A little bit, as we said.
how do you call it when the patient and the one who enrolls the patient knows, but the one who's blind is the investigator?
Single blind, so it's
It's
single
still
blind,
single,
single or double. So single could be investigator blinded or patient.
So it's still
patient
single.
blinded.
Okay, it's
So
the
single
same.
blind, yeah. Yeah, so you know, if you're doing one town versus another, it's not blinded. If the intervention is behavioral, it's not blinded. If there's no,
The town versus the other, it might be for the
might be for the,
investigator, might not know who came from which town. He gets a file
Yeah.
of
so for example,
data and he doesn't know who came from which town. So this,
yeah.
that way he's blind.
So you're doing town one and you remove the names of the town, and one is town one and one is town two. And the investigator doesn't know which one is which, or the person looking at the data doesn't know which one is which. That is a form of blinding. But the people in the town know whether they.
But they might not know if they do the placebo or the intervention or
yeah,
what.
in a drug trial,
Or that
generally,
you're
you don't know.
investigating the level of fluoride in the water. They just know that you're taking some blood samples every
Could be.
week and they don't know what you're investigating.
Well, except you have to consent them. I mean,
So you can say, I'm investigating the level of fluoride in the water and how it affects your teeth. But they don't know if their fluoride level in the
it
water
could be.
is high or low.
It
They
could
don't
be.
know.
It could be.
They just know
Yeah.
they are blinded.
Yeah.
You can tell them that
It could be, but it depends. I mean, you know, for things like this, generally you cannot, especially with internet and everything, you know, like fluoriding the water in, you need a regulatory approval, and it will be, you know, if you
no,
dig
not
enough, you will
always
find
you
it.
can blind
Yeah,
completely.
exactly. We have the same problem. We discussed this in cohort studies. Follow-up, loss of follow-up is a problem, and it's really only a problem if it's different in the two groups. And generally, if people are blinded, it's harder because they don't know, you know, like if they're not blinded and they know they got a placebo, for example, they're not going to be they're going to be less motivated to
Right.
continue. But if they're blinded and they don't know, well, they're more likely to continue. So that's why blinding also reduces the risk of
Right.
loss of follow-up bias. So here we're looking at an example of using microbicide gel and HIV. Okay, so you want to know whether using a microbiocid gel before sexual intercourse decreases the risk of HIV transmission. This is a real trial in South Africa. Okay, so your intervention is women receiving tenofovir gel, an antiviral gel, and the control is women receiving. So you can't give them nothing. You give them a gel, which is basically a water gel. There's no antiviral. And this is only ethical if you really don't know whether it works or not. Right. So so this is a little bit like thinking back about the PICO. Who is your population? What is your intervention? You control. Really helps you. So you can see it's a prospective study that will follow patients up to 30 months. And the intervention is the antiretroviral gel. The comparison group is a placebo. People are randomized, so they're either given the real gel or the placebo gel. Neither the participants nor the researchers know whether they received the real thing or not. And the best way to avoid loss to follow-up is to follow each patient exactly in the same way. This is another thing, if you say, for example, you want to know what happened after 30 months is almost 3 years, it's quite a long time. And one way to know is to phone people and say, did you receive a diagnosis of HIV? If you do it, if maybe you will ask a little bit harder in the intervention group. You will try phoning more often than in the other group. That is a form of bias. So that's why blinding, if you can blind, it's the best thing to do. And in an RCT, you generally measure, like cohort studies, you measure risk or rate, and then you do risk ratios or rate ratios. You can also measure risk difference. You can also do this in cohort studies, by the way. And the risk difference is, instead of saying, so the risk ratio is, one group is 3 times more likely to, it's a multiplication. Risk difference is a subtraction or a subtraction or an addition. So you say, compared with the control group, say for example, you want to measure, let's say you do a vaccine effectiveness trial, and you say compared with those who didn't receive the vaccine, there were an additional 700 cases. That's a risk. That's a difference. One minus the other. The ratio is 1 divided by the other. And the other thing you can do in a randomized controlled trials is numbers needed to treat, which is a very nice thing, and tells you how many people you need to give a treatment to prevent one case. Yeah.
And the hazard ratio.
How many children need to get a head CT with my protocol
Exactly.
in order for them?
In order to detect one.
In order to detect one clinically important traumatic
Exactly,
event.
exactly. Hazard ratio is
a risk.
hazard ratio is a ratio. So hazard ratio is it's a survival study. So you take people and you look how they do over time. It's a form of observational study, but it's measured slightly differently in oncology. It's highly relevant. It's not. We didn't really do survival analysis in the course.
Okay.
Maybe it's something that we can talk about separately because it's relevant to oncology particularly. Another really important feature of RCTs, and you will see this in the papers, is intention to treat analysis, right? So generally, if you read an RCT, you will see the data was analyzed using intention to treat analysis, which means that in real life, you assign people to an intervention and control, right? But some people who were assigned to the intervention group will end up not receiving the intervention, and some people who were not assigned the intervention will end up receiving it. Like, for example, if you're doing your study and you assign a group of people to running and not running, well, some people will be signed up but end up not going running, and maybe someone independently will decide that they want to run outside of your trial. you shouldn't switch them group. You should stick to
That's what we
whatever
talked
group
last
they
time.
were assigned. Yeah,
More conservative on that.
yeah, exactly.
Is it worthwhile sometimes asking about running? Asking the controls in the intervention group about
You
it?
could,
Maybe at the
could,
end, or-
maybe at the end,
We started
and you could
running.
adjust for that. But the reason it's important, is because it mirrors things closer to real life. In real life, not everyone is 100% compliant with the treatment. Not everyone does what you tell them to do when it comes to medical intervention. And people also do their own thing. So it's kind of a better measure of what will happen in real life. If you're doing what's called a per protocol analysis, you basically remove from your intervention group people who didn't receive the intervention. And generally, especially for commercial trials, people love this because it gives you better results. But it's not as.
Yeah, but you're saying in real life, I'm gonna give this amount of people the drug. I wanna take into account that some of them will not
Like,
take
let
it.
me give you an example. Say you have a cancer treatment that is really highly toxic and like people suffer horrible side effects, and you give but it's very effective. If you go through the treatment, you will do very well, but going through the treatment is hell. Okay, imagine the situation, which is not far from the truth. So say you take 100 patients, and only of the 100 patients, only 10 go through finish, right? So if you do a per protocol analysis with only the 10 patients, the results will be very, very good. If you do an intention to treat analysis, it won't be so good. But what you want to know is not, there's two different things. One gives you the kind of the biological effect of the treatment, but what you're really interested in is, if I use this in my service, will it help my patients? If everyone drops out, maybe it won't.
Efficacy versus
they-
effectiveness.
Efficacy
It's like
versus
Zinat in
effectiveness.
children. The pediatrician write an antibiotic called Zinat, and the children, it's bitter, and the children, they just don't take it.
Exactly.
So they keep writing it,
And
but
no one
no
takes
child
it.
takes it.
Yeah. So that means it's
So-
not, it may be an excellent, maybe an excellent
Antimicrobial
active, maybe an
drug,
excellent
but-
active
but
ingredient,
Zero
but it's not a good
compliance.
treatment because no one uses it.
לא, זה טעם שלילדים בסירופ, לא אפשר לקחת, לא טוב, אותו אי אפשר. כן.
Okay, we can discuss specific treatments. So as we said, RCTs, people think of drug trials, but RCTs are much larger than that. They're not just trials of drugs, and particularly in the type of work we're interested in, which is kind of clinical, real-world clinical research. You can think of a lot of intervention trials that are not drugs, running, screening in an emergency department. So you could have two groups, one that receive, one that don't. That's a randomized controlled trial. So RCTs are, the strongest, the purest type of research, in the sense that if you do it well, you don't have to worry about bias, and you don't have to worry about confounding, or at least not anywhere near the extent you need to worry about it in observational studies. And also, you're sure that the exposure happened before the outcome, because you give the exposure and you measure the outcome at the end. But it's not that you have to use this design in everything you do, because first of all, they're very expensive, time-consuming, and complex. And you have to think, when you're talking about a case control study, for example, versus this, you have to think, is the extra money and effort worth it? Sometimes it is, sometimes it's not. And some things you can't do an RCT on, because you cannot ethically expose people to anything harmful, and you cannot not give them something that you know is beneficial. So you have to really
Even
know.
have some medical and ethical problems, no?
Sorry?
Like in my study, the meta says it's not unethical. But I
No, it's
wanted
not
to give
unethical.
them running therapy and to give
Because
them
you
a
believe in
lecture.
it, but there's no evidence.
You don't know. You think
Then why are you doing the study if you don't?
Well, there isn't hard enough evidence.
no, but look, there's a difference between knowing that running is good for you in general and knowing that running is good for particular psychiatric diagnosis. It's a different thing. So I think it is.
I think it's good
okay.
for anorexia. It was a
excluded.
joke.
It will be excluded. Yes or no?
Also
Running is good for if you wanna run.
Also
So the
happens.
basic science evidence shows that if you don't wanna run and someone makes you run, it's not good for you.
Interesting.
So I don't know what happens in human and psychiatric patients.
Yeah.
What happens with the girls that don't wanna run and you make them run?
We'll find out.
Fall in love with it.
maybe they'll fall in love with it. So you will see this. You will see this all the time. You will see this all the time. I just want you to be a little bit. I want you to be a little bit
Okay.
critical about this, because what I want you to think about is not which one is better than the other. But what I want you to think about is which one is suited for this particular. So when you read a paper, saying, "Oh, this is a rubbish study because it's not a randomized controlled trial," that's not a good approach. The good approach is the design that you choose in your work and the researchers chose in their work when you read a paper. Is it appropriate for the question that they're asking? That is the important question that you need to ask yourself, right? So there's a whole science to randomized controlled trials, and today I just want to give you a very quick overview. They're very powerful tools, obviously, and if you want to test an intervention, they're really your only good option. And randomization is really the key to RCTs, because it to a large extent eliminates confounding, and blinding also helps eliminate bias, but they're still not completely free from bias because you can have loss to follow up. And yeah, the design is important. The last point is important. Just saying I'm doing an RCT is not enough. You have to do a good RCT. And if it's not a good RCT, maybe you're better off doing another design better. You have to look at your budget. You have to look at what you can afford.
What do you call a cohort?
Yeah.
How do you call a cohort of intervention, but without randomization?
That is called a single arm non-randomized trial.
What I'm doing, because if every woman comes with the child, I'm doing the screening.
No, but your purpose is not to. Your purpose is not. You're not testing the effectiveness of an intervention. You're detecting burden of disease in the population.
We changed it a little bit, and now we're talking about finding women that weren't diagnosed before.
Yes.
So it is the effective level by screening in the ER.
Yeah, but it's not. I wouldn't call it. The objective here is not really to intervene. It's really to detect. If you were saying, I want to do like a treatment,
that were
like
not detected before. Or did not get an intervention.
I wouldn't call your study an intervention study.
Okay.
It's you basically screening for undetected cases.
Okay.
It's a little bit. An example of a bad trial would be, like for example, the hydroxychloroquine trials for COVID-19 that they did in France, where the head of infectious disease department says, "Oh, I gave all my patients this drug, and look, 80% got better and were discharged. Therefore, this is a wonderful treatment." That is a very good example of a very, very bad design, because you have no idea. Maybe if you didn't give them anything, 80% would have been discharged anyway, which is when you did the same thing using a control group, and randomization is exactly what. Yeah. Good. So that I'm going to stop the recording.
It's a good question.